We had Lawrence Klotz, who is one of the pioneers in this concept of active surveillance from Toronto in Canada, who updated where we are in terms of guidance, and clearly he now showed that for very low risk patients or low risk patients, active surveillance should be offered, and in many of the guidelines should be the preferred first line option. And then we had the honor of having Freddie Hamdy from the UK, who led the largest study ever done in prostate cancer, the Protect-T, that was just published in the New England Journal, looking at the 10-year outcome of patients who were screened and then randomized with prostate cancer to either active surveillance, radiation therapy, or surgery. And he presented the results that at 10 years, there was only a 1% cancer-specific mortality rate, regardless of which arm you were randomized to, which is, I think, very thought-provoking that these patients with, for the most part, low-risk cancers are at very low risk of dying over 10 years. And so I think that adds to the credibility of offering active surveillance as a first-line setting for low-risk patients. And then we had other very interesting discussions around the role of imaging in patients on active surveillance from one of the leaders in imaging in the UK, and also the role of MRI that will play in terms of diagnosis and also in terms of active surveillance. And then a discussion with Lorelei Mucci on the role of biomarkers in helping to predict patients who might be inappropriately managed with active surveillance versus those that would be most appropriately managed. And we're still a little bit away from using biomarkers in our decision process, but we're headed in the right direction between imaging, biomarkers, and also reassuringly, even with the little we have, we're doing a pretty good job in not harming patients by offering them active surveillance as a first line for low risk prostate cancer.